Hello everyone, hope you're all doing good. In this video, we are going to discuss about induction of labor. See, first I want to know the difference between two terms, okay? It is induction and augmentation. So, what is induction and what is augmentation? See, induction means we are using some methods to stimulate uterine contractions, okay, after the period of viability of the fetus to bring about natural labor. Remember, the word I have to stress here is stimulate, okay, we are going to stimulate, okay, the uterus is in a quiescent phase only, we are going to stimulate it, okay, whereas what do you mean by augmentation means there has been some normal natural contractions that have started, but they are not sufficient enough to bring about cervical effacement or dilatation, right? So, here what we are going to do is, we are just going to help the process, okay. So, we are going to enhance the already happening spontaneous uterine contractions which are inadequate, okay. So, that is the word you have to know, clear? So, these two process difference you should know, right? We will see the indications now where we have to do induction or augmentation of labor, okay. So, we will see the maternal indications as usual. Maternal indications include conditions where there is a postdated pregnancy, when there is premature rupture of membranes or premature preterm rupture of membranes, or there is placental abruption, when the mother has diabetic mellitus or systemic hypertension, when there is polyhydramnios or oligohydramnios, and then there are conditions like chorioamnionitis, okay. Now, we will see the fetal indications for induction of labor. These include fetal growth restriction, RH alloimmunization, non-reassuring fetal heart rate, then intrauterine fetal death. Clear? Now, we will see also the contraindications of labor induction, when labor induction shouldn't be done and some other decision has to be taken, maybe a cesarean section. Clear? So, contraindications of labor induction. See, when there is an abnormal presentation of the baby, okay. So, what are the abnormal presentations you know? Anytime cephalic presentation is normal. So, other than that, if it is a breech presentation or it is a brow presentation or it is a face presentation, then it is going to be an abnormal presentation. Clear? And even if the lie is abnormal, like longitudinal lie is the normal one, when it is a transverse lie, then we can't induce, right? So, labor is not going to happen in that case. Then, regarding the pelvis, when there is cephalopelvic disproportion or there is a contracted pelvis, definitely we are not going to induce. Or about the placenta, when there is placenta previa or when there is vasa previa. So, that is why you have to rule out placenta previa or vasa previa, especially you have to rule out placenta previa since it is a more common condition, okay, before induction when the woman is presenting, especially with the antepartum hemorrhage, okay. Then other conditions, there can be umbilical cord presentation also, okay, umbilical cord presentation can be there, or there can be a severe fetal growth restriction in the baby, or scar on the uterus For example, definitely we are not going to induce if the patient has undergone a classical cesarean section before, right? And when there is active maternal genital herpes, we are not going to induce. And the last one is invasive cervical cancer is present in the woman. Clear? Okay. Now, we'll see what are the prerequisites for the labor induction. Prerequisites for labor induction. First point is, you have to do a vaginal examination and cervix has to be assessed for its effacement and dilatation, right? So, cervix must be assessed. Then, pelvic assessment should be done simultaneously, right? So, pelvic assessment. So, here we have to rule out CPD or contracted pelvis, right? Then, you have to check for the characteristics of the fetus, okay? Like, what is the presentation? Mostly, I already told you, the favorable presentation for induction is cephalic presentation. Then, you have to know about the station, okay? Station, at least it should be engaged. The fetal head should be engaged, because only when it is engaged firmly into the pelvis. See, if you think this is the pelvis and the fetal head is fitting into this position, there will be no other space available. Otherwise, what will be happening if there is a gap like this? What will be going to happen? The other thing that is present in the uterus is umbilical cord, okay? So, what happens? Through that space, umbilical cord is going to prolapse, and this is going to get compressed between the fetal head and the pelvis, and it will lead to complications. Understood? So, it should be engaged before starting induction of labor. And the next one is, you have to know the gestational age. Mostly, you have to do it after 37 weeks, or ideally however prolongation of intrauterine life you can give, you have to give, okay? So, gestational age has to be assessed. Then, you have to assess for the fetal weight also, very, very important, okay? You have to assess for the fetal weight. Then, you have to assess for the fetal well-being as well, right? So, all these factors has to be assessed before starting labor induction. So, we have to know about modified Bishop score, which is helpful in assessing the cervical effacement and dilatation, okay? And ideally, during every labor, when the first assessment of cervix is made, okay, when the first vaginal examination is made before induction of labor, this assessment should be complete, okay? That is, you have to evaluate the modified Bishop score for each and every pregnancy before induction of labor. Clear? So, we'll see the modified Bishop scoring system. See, this is very, very important system, okay? You will be asked about this in the Viva as a short answer, and when you are asked to write induction of labor, the essay won't be completed without this, and it is very important for your MCQs as well. Clear? So, we'll see. First, you have to know the scores of modified Bishop scoring system. The scores will start from 0 and it will go as 0, 1, 2 and 3. Clear? And you have 5 factors in assessment, and you have to keep the following alphabets as your favorites, okay? It is C, D, E followed by your P, leave Q, R, then S. Okay, C, D, E, P, S should be your favorite. Clear? Now, the first factor is C for consistency. So, consistency of cervix. And the second factor is going to be dilatation of cervix. Third factor is going to be cervical effacement. Fourth factor is going to be position of the cervix, okay? And fifth one is going to be the station, that is the fetal station. Okay. So, the first 4 factors are about the cervix and the last factor is about the fetus. Okay. So, we will see the values that are given. For consistency of cervix, we have to see the consistency of the cervix and we have to name it as firm, medium and soft. Okay. That is nothing for score 3 here. And dilatation of the cervix, remember the cervix will be closed at first, right? So, it starts from 0, okay? Then 1 to 2 centimeters, 3 to 4 centimeters and it is more than 5 centimeters, right? And for effacement, it is given in centimeters and remember the normal cervical length is going to be more than 2 centimeters, right? So, first it will be more than 2 centimeters and effacement means taking up of the cervix into the lower uterine segment, right? So, obviously the effacement is going to reduce. So, it will reduce like this 2 to 1 centimeter, 1 to 0.5 centimeter and then less than 0.5 centimeter. Okay. And then position of the cervix, position of the cervix can be posterior, central or anterior. Okay. Here also there is nothing for the score 3. And fetal station, you should start with the highest station first. So, it is going to be -3. Okay. Then comes -2 and -1 or 0 means you can give a score 2 and anything below the ischial spine level, that is below the 0 station, that is after 0 it is going to get a score 3. Okay, so this is the modified Bishop scoring system. So once again we will revise this. Your favorite letters for putting the table of modified Bishop scoring system is going to be C, D, E and PS and the scores will be starting from 0 and it is there up to 3. C for consistency of cervix, D for dilatation of cervix, E for effacement of the cervix, P for position of the cervix and S for station. Okay, the first 4 factors are for the cervix and the 5th factor is for the fetal station, right? So, consistency of the cervix, it is going to be firm, medium, soft. Dilatation of the cervix, it is 0, 1, 2 and 3, 4 and then 5. Effacement of the cervix, we have to reduce the length. So, it is going to start from above 2 centimeters, then 1 to 2 centimeters and then 1 to 0.5 centimeters and less than 0.5 centimeters. And the position is going to be posterior, middle and anterior. Remember the anterior position of the cervix is going to be the most favorable one. Here you don't have anything for the score 3. And fetal station, you should start from the highest fetal station. So, -3, -2, -1 or 0 and anything below the ischial spine level, that is after 0 station is going to get a score 3. Clear? You have to do cervical ripening when the calculated Bishop score is less than 6. Okay? So, for cervical ripening we have 3 methods. Number 1, you can go for sweeping of membranes. Number 2, you can do pharmacological methods of cervical ripening and number 3, you can do mechanical methods. Okay. So, we will see one by one now. First one is sweeping of membranes. Sweeping of membranes means it is also known as stripping of membranes. See, this is how we do sweeping of membranes. First, we have to insert a single finger through the vagina into the cervix and we have to rotate through 360 degrees and we will be making sure we will be stripping off the membrane from the cervical wall. Okay. So, if you are able to see this picture, this is before membrane sweep. See, there is a attachment of the membranes here, right? So, you are able to see the membranes are attached over here. But after sweeping of the membrane, while I am stripping this membrane, okay, from the lower uterine segment, 360 degrees rotation also we have to do. We have to sweep it like this. Okay, when you do this, you will be having the membranes getting separated from the walls of the cervix. Clear? So, this is known as stripping of membranes. If you ask me what is the advantage of this method, why we are doing this? See, while doing this procedure, there will be release of prostaglandin F2 alpha from the adjacent decidua. Okay, so this is going to stimulate the labor and there will be natural labor progression. Even just with stripping itself, many women have delivered naturally. Clear? Yes. But the risk factors are also there with any procedure. So, the risk factors include there can be pain, discomfort, bleeding, or sometimes accidental premature rupture of membranes can also happen. Clear? Yes. And the next one is pharmacological methods. So, pharmacological methods include, we have to supplement prostaglandins. Okay. So, prostaglandin E1, which is misoprostol, and prostaglandin E2, which is dinoprostone. Okay. So, if we take prostaglandin E1 is available as a 25 microgram or a 100 microgram tablet. Okay. Usually for labor induction, we will be using a 25 microgram dose only. So, if you have a 100 microgram tablet, you have to break it into 4 pieces. Clear? So, the routes of administration of misoprostol can be oral, vaginal, or even buccal and sublingual. Repeating. The routes of administration of misoprostol can be oral, buccal, sublingual, or even a vaginal administration can be done. Okay. So, if you give a oral misoprostol, you can give it at a dose of 50 microgram Q 4th hourly or 25 microgram Q 2nd to 4th hourly. Okay. And remember, the maximum number of doses you can use is 6 doses you can give. Clear? And suppose if you are planning to give a vaginal misoprostol can be given at a dose of 25 microgram Q 3 to 6 hourly. Okay. And here also you have to give a maximum of 6 doses. Clear? Now, we will see the side effects of misoprostol. Side effects of misoprostol include nausea, vomiting, then there can be sometimes transient elevation of temperature that is associated with chills. There can be diarrhea, headache, then there can be fall in BP, especially the diastolic BP. There can be a fall more than 20 milligram mercury even. Okay. Then there can be tachysystole, especially with vaginal misoprostol. So, what does tachysystole means? There will be more than 5 contractions in 10 minutes. Clear? Yes. Now, we will see about prostaglandin E2. See, here you have 2 forms. Okay. So, 2 forms are available. Number 1, it can be a intracervical gel which is available in the dose of 0.5 milligram in 2.5 milliliter of gel. Okay. And this can be given every 6th hourly and maximum you can give 3 doses. Clear? So, this is an example of the gel form. Okay. So, this is available as dinoprostone gel. See, this is not for any promotion of brand, this is just for educational purpose, right? And then the second form can be an intracervical insert. Okay. here you have 10 milligram dinoprostone in a timed release formulation that can be released as 0.3 milligram of prostaglandin E2 per hour, okay, and it will be going on for 12 hours, okay, or till the active labor begins, Clear? Yes. Next one is, we have to know about the mechanical methods, okay. So, mechanical methods of labor induction include 3 options, okay. Number 1, we can use a cervical catheter. This can be a Foley's catheter or a double balloon catheter, okay. Then you can go for transcervical dilatation with EASI. EASI means extra amniotic saline infusion, right? And the third type is, you can prefer to use hygroscopic dilators. Understood? So, these are the 3 methods. Now, we will see one by one. So, the first method is transcervical Foley catheter. You have to do it under speculum guidance, and this should be done ideally under aseptic sterile precautions, okay. So, mostly we will be using a 16 number Foley's catheter that will be inflated with 30 to 60 ml of saline solution. So, this is how bladder inflation is done, okay. So, you are going to insert the catheter and the bladder is going to be here, okay, and this is being instilled with 30 to 50 ml of saline, and what is going to happen is, if you see this pics, you will be able to see that there is progressive effacement. Effacement means the length is also getting decreased, as well as there is also dilatation. Clear? Yes. What you have to do is, you have to pull the Foley's catheter and you have to tie it to the maternal thighs, okay, and you have to tape it tightly, okay, so that it won't be falling back, and this should be kept ideally up to 2 to 3 centimeter dilatation till it spontaneously falls out, okay, or it can be kept even up to 24 hours after insertion. Clear? Right. So, the next one is EASI, that is extra amniotic saline infusion. What you are going to do is, there is a constant supply of saline that is going to be present between the membranes and the cervix, okay. So, that is the thing. And next is about hygroscopic dilators. We will see about hygroscopic dilators. Hygroscopic dilators can be dilapanes or laminaria. So, what is going to happen is, this is going to absorb moisture and it is gradually expand, okay, that is going to lead to cervical dilatation. So, this is how dilapanes is going to work, okay. So, this is how, when we have inserted, okay, then after 2 hours, after 4 hours, after 8 hours and after 24 hours, you see the change in width, right. So, this is going to cause cervical dilatation, right. Now, so we will see about oxytocin drug. So, this is an important drug that is used for augmentation, okay. So, it is an octapeptide which is available in the synthetic form, and most common drug that is used in induction of labor. It is given as an IV infusion, okay. Mostly it is not used orally because it will be degraded, okay. So, it is degraded to an inactive form. So, this is oxytocin. Okay, you are able to see oxytocin. So this is the ampule of oxytocin. So you are able to see that there is 1 ml of oxytocin in an ampule, and that is going to contain 10 units. Okay. So how much oxytocin we are going to use is, we are going to use 5 units of oxytocin in 500 ml of normal saline. Okay. So what will be the concentration of oxytocin now? Concentration of oxytocin will be 10 milliunits per milliliter. Okay. And remember, always oxytocin should be administered through an infusion pump, and the half-life of oxytocin is around 3 to 6 minutes. And when you give oxytocin, the plasma steady state will be reached in another 40 minutes. And uterus contraction, okay, uterine contraction will begin within 3 to 6 minutes, okay, between the T-half time itself, okay. So we have so many regimens for administering oxytocin. Regimens of administering oxytocin include a low dose regimen or high dose regimen. Okay. So it can be given like this. We have to know at what dose it is started and at what increment the dose should be increased, what is the incremental dose, and what should be the dosage interval, and then what about the risk of tachysystole. Okay. So if you see the low dose regimen, the starting dose is around 0.5 to 2 milliunits, whereas in the high dose regimen we are going to start it at 6 milliunits. Okay, and the incremental dose should be 1 to 2 milliunits per minute, whereas for the high dose regimen we are going to increase it at rate of 3 to 6 milliunits per minute. And the dosage interval should be ideally 15 to 40 minutes in both the regimens. Okay, so that is every 15 to 40 minutes you have to check for the contractions and you have to increase the dose of oxytocin. Okay, and tachysystole will be less in case of low dose regimen, and obviously it will be more in the case of high dose regimen. Okay, so what is the advantage is that it may be associated with a short labor. Okay, and another important point you have to know is, what is the maximum dose of oxytocin you can give. Okay, maximum dose can be between 32 to 40 milliunits per minute. Clear? So once you started increasing the dose and at a particular level of oxytocin, you are able to get a sufficient amount of contractions, then it should be maintained at a plateau till delivery. Clear? Right. Now what are the side effects of this drug? Side effects include water intoxication that will be leading to hyponatremia. So, if you give a high dose oxytocin, that is 40 milliunits per minute, especially with the hypotonic solutions, this risk is considered to happen more. Okay, and this will lead to obviously excessive water retention and excessive hyponatremia as well. So it can be prevented by using more concentrated. Okay, so this is what you have to do. You have to use more concentrated solutions of oxytocin. That is, you have to use 5 units of oxytocin in 500 ml of normal saline, and you have to avoid increasing it after 32 milliunits per minute. Clear? So how you are going to manage this hyponatremia? So management is ideally done by stopping the infusion, then you have to correct the hyponatremia, then you have to restrict the fluid intake. Okay. Yes. And we have to know about artificial rupturing of membranes also, which is another method of augmentation of labor. See, so mostly it is performed for augmentation, especially when the progression of labor is very slow. Okay. And what you have to do is, under aseptic sterile precautions, you will be using 2 fingers, okay, that will be inserted into the cervix, and the membranes has to be palpated first, and then you have to rupture the membranes by using either an artery forceps or a coach's forceps or an amnio hook. Okay. See, this amnio hook is nothing but a glove with one pointed projection. Okay. That will be helping in rupturing of the membranes. So, this is the picture where it is shown how they are doing rupturing of the membranes by using a forceps or artery forceps, coach's forceps, anything. So, what they are doing is, they are just leaving 2 fingers inside. They would have palpated already, and with some repeating again. So, this is the pic to show how they are doing artificial rupturing of membranes. First, you have to do a pervaginal examination. You have to assess the cervical effacement, dilatation, and then you have to feel for the membranes, and then you have to insert the forceps under a controlled manner, and you have to rupture the membranes. And this is a amnio hook. You are able to see that there is a pointed projection that will be helping in rupturing of the membranes. Just you do a pervaginal examination and give a touch of the membranes, it is going to rupture. Clear? Yes. Now, what are the complications you expect with this? So, complications include, there can be cord prolapse if you are going to rupture it very soon. So, always you have to give a suprapubic pressure or fundal pressure while doing rupturing of membranes, and FHR should be checked both before the procedure as well as after the procedure. And remember, there is risk of chorioamnionitis even when the labor is prolonged. Clear? Then you have to know what will you do if there is uterine tachysystole. So, when there is uterine tachysystole, you have to stop the oxytocin infusion first. Okay? Then you have to place the woman in the left lateral position. Then you have to give IV fluids. Okay? A bolus of 500 ml of ringer lactate should be given, and then you have to give her oxygen supply also at a rate of 10 milliliter per minute, and you can even give terbutaline at a dose of 0.25 milligram subcutaneously or as an IV infusion, and you have to reduce the dose of incrementation. Okay. For example, suppose if you are giving at a 3 milliunits per minute, you can reduce the dose of incrementation to 1 milliunits per minute. Okay. Now, we will see the general complications of induction of labor. Okay. So, what are the complications of induction of labor? Complications of induction of labor include, already as we have seen, there can be uterine tachysystole, or sometimes there can be chances of uterine rupture also. Then sometimes it can end in failed induction. Okay, suppose there is no progress in the Bishop's score even after 24 to 48 hours, then it can be considered as failed induction. Then there can be chances of prematurity if induction of labor is done prior to the gestational age, early in gestational age. Then there is chance of sepsis, which can be accompanied by chorioamnionitis. Then already we have seen there can be chances of cord prolapse or amniotic fluid embolism. Okay. So, with this we are finishing this topic on induction of labor. Until we meet in the next video, take care, happy learning, and bye-bye.